All right. I have 12:30 on my end. Just make sure everyone can hear me okay?
Yeah, we can hear you.
All right, awesome. So let's get started. This was a topic that was requested by student Dr. Swanberg for this evaluation of thrombocytopenia. We had a patient who had low platelets, but it never seemed to have been worked up, and we kind of did a very brief differential. So this is going to be a rundown on thrombocytopenia. Maybe. There we go. So some of the objectives, just be able to identify what's the diagnosis, meaning what level do we actually get concerned about thrombocytopenia? What are the different levels that affect when you would actually need to get involved, meaning what's the absolute level? What is it for neurologic surgeries, different type of surgeries that are non-neurologic, et cetera? And what kind of workup would you do in what systematic order? And then list the common causes based on the major physiologic or pathophysiologic etiology that you're likely to see both in the inpatient and outpatient setting. So to start off, the normal platelet count is a very wide range, 150 to 400. So based on that range, anything that's less than 150 would theoretically be thrombocytopenia. But as you'll see later that we'll talk about, it doesn't necessarily mean that it necessitates a workup or even aggressive management. Normal decreases do occur in pregnancy. It's termed gestational thrombocytopenia. We don't see that many pregnant patients, but just know that it is not a abnormal thing. But think about the HELP syndrome, because when it is associated with like liver enzyme elevations and hemolysis, et cetera, it can be completely it definitely would be threatening to the mom. Some of the conditions are associated with underlying conditions that can increase your risk for thrombosis. So it's kind of, I guess, paradoxical in the idea that you have low platelets, but despite having low platelets, there is still a risk to be aware of. And that's going to be our HIT, or antiphospholipid antibody syndrome, and even our patients that have cancer. When you get to that severe level, it's defined as less than 20,000, but a big note to remember for this talk is that 30,000 is that range you want to remember, because once it's 30,000 and below, that's when the patients have a higher risk for bleeding and complications from that. So that's when, just regardless of what's going on, you'd probably want to consider treating it. So brief things that we're going to talk about is just that general approach. That's probably one of our objectives, as well as ITP. I'll have one slide on HIT. HIT, it's, my opinion is it's an entire different topic. So I didn't want to feel like I was going to go over it for the rundown perspective. So we're going to go over a case, and then I'm going to go back to the case after we go over the evaluation and management of thrombocytopenia, so you can know how we would probably manage it. So we have a 32-year-old female, normally was pretty healthy. She's had some nosebleeds, though, that is prompting her to come and see you. They occur multiple times a week. She's also noticed that she has some mucosal involvement, especially when she's brushing her teeth. She has no family history, though, of bleeding problems, because you might be going down like the Willebrand's disease pathway, et cetera. She's had no tonsillectomies or adenoidectomies. Oh, she had both of those, sorry, at age 7, and her wisdom teeth were removed, but at those times, she didn't have any excessive bleeding. You checked a CBC, a coag panel, with PTT, PT, and INR, and they all seem to be normal. But the CBC comes back, and you find that the platelet count is less than 10,000. So you send the patient back to the lab, because you're like, there's no way. Why would this be completely normal except for the platelet count being severely low? And it comes back in a blue top tube, which is a heparinase tube, and it's found to be less than 10,000 again. So you order a peripheral smear, and you know that there's large platelets with normal morphology. So we're going to go through the talk, and then we'll come back to this case. So what are some important questions to ask? I felt this is probably the best way to start, because sometimes we don't even know what we should ask or present, on our medical presentations and rounds. Look for neurologic issues, right? Because that's going to affect the threshold that you're going to treat. You're not necessarily going to wait for them to get to 30,000. Do they have a family history of it? There's the major breaking point or division is if it's acquired versus congenital. So if it's an acquired, which is the purpose of this talk, you're going down an entire different pathway, versus if it's an inherited issue, you don't have to really go down that acquired pathway, because you're going to be getting different labs. So again, the purpose of this talk is not to go over the inherited thrombocytopenias, but the acquired. You're going to find out, does the patient have a true thrombocytopenia or pseudothrombocytopenia? So that's going to be when you repeat the lab in a heparinase tube, because the platelets can actually be counted as low or be affected by heparin, which we'll talk about briefly in the next few slides. You want to know about the timing. Is this a sudden onset, or is this something they've had their entire life? Again, going back to that acquired potential source. And do they have maybe some other conditions, secondary causes that could be related to this? A lot of times the secondary causes, while we think about them for every condition in our differential, as we'll be getting into the next section, which will be rheumatology, you'll see with vasculitides, the majority of them are related to some secondary cause, and thrombocytopenia is no different. So know about or ask about any history of exposures to any of these conditions. And then you want to know if it's isolated or if there's any other condition like anemia, leukopenia, or even all three, because if you have all three, you might be thinking of this being defined as pancytopenia, and then your evaluation might focus on the bone marrow itself and not necessarily other organs like the spleen that might be relating to just the splenic or the thrombocytopenia itself. And then obviously looking at the peripheral blood smear to get a visual analysis of those platelets, as was done in the case. So this is a flow chart, and then on the next slide, I'll be going over a different way of looking at the same exact information. So once you see that someone has thrombocytopenia and there's no family or genetic history that would otherwise suggest a congenital cause, you should repeat the level, and then once the repeat comes back and it's still low, you're gonna look at the platelet smear itself to look for the clumping itself. And once you look at the smear, it's going to allow you to know if this is going to be increased platelet destruction that's going on. Maybe you see some hemolysis going on. It's going to be decreased production itself. So it's either destruction or production, or there's just a problem with the distribution of the platelets themselves. So if we go down the left side, we see that there's a problem with platelet destruction. That could be something with ITP. It could be HIT, which again, I'm not going to be really talking about. It can be from an infection like HIV, a lot of your viral causes. You can get autoimmune. I'm not going to get into the neonatal causes, or it can be some non-immunologic process that is causing platelet destruction like TTPHUS, the HELP, which I talked about with pregnancy, or it could be that there's some artificial device like a valve replacement that can cause those, or even like ports, etc. But what if we thought that this was a decreased platelet production? So for some reason, we just don't have enough platelets. It's not that they're being destroyed by the time they get out of the bone marrow. We just don't have enough of them. That you're still thinking infection. So HIV can still be in that because it can directly impair bone marrow development. We're thinking chemotherapy. Maybe there's a medication they received that directly acted on the bone marrow itself. And it might not just be the chemotherapy, but the malignancy itself that's treating the chemo, like leukemia, lymphoma, might be something that we're thinking, as well as deficiencies in vitamins. So you know, with the vitamin B12, we expect, or even folic acid, to see an effect to the hemoglobin as well. But we know when it comes to like alcohol toxicity, it doesn't always affect, you know, the hemoglobin. Most commonly, we'll still see that macrocytic anemia because of the alcohol itself, but alcohol can also have just direct destruction to the bone marrow, which can cause the thrombocytopenia. So in our patient, that was one of the things we were considering in the hospital. And in these kind of patients, or when you're looking for the decreased production, that's when you're doing more of a bone marrow evaluation. Whereas if we went to the platelet destruction, we're thinking more of looking at the whole body itself and looking at the smear specifically. Or it could be that the platelets are just not being distributed to the rest of the body. So it could be from cirrhosis itself. There's that portal hypertension that develops that we heard about with our grand rounds on Wednesday that causes the pressure to back up even to the spleen, and then you see some vasodilation that reacts, et cetera, et cetera. So cirrhosis would technically be on this. But if we want to go and look at the same conditions, but in a different format, just to, again, be helpful for those of you who don't like the flowchart format, we can put them into boxes. So we can again go decrease production, we can do increased destruction, and then splenic sequestration. So decreased production, again, it's going to be a bone marrow issue. You're going to typically see decreased hemoglobin as well, and if not, a combination of the white count being involved. These can be acquired through aplastic anemia, myelodysplastic syndrome, or leukemia. You might have chemotherapy, infections, all the nutrition deficiencies from B12 and alcohol, like we talked about. Or it can be destruction. You might see some DIC or HIT going on. It could be mechanical secondary to an indwelling device like a catheter, or even if someone's on ECMO in the ICU. Von Willebrand's disease, you'd hopefully see some potential family history being involved, but maybe the patient is intubated or you're not able to able to talk to them about the family history. That's something to consider. But it'd be type 2B specifically that affects the platelets otherwise. Von Willebrand's is going to be affecting the hemoglobin and the coag factors. TTPHUS, as I mentioned earlier, sepsis itself on its own can cause destruction. Again, kind of going back to the infections, HIV and the hepatitis being the specific viral infections that we get concerned about. And then the splenic sequestration, which fell back or went back to this abnormal platelet distribution that we talked about. Again, remember cirrhosis, your myeloproliferative disorders, which was also seen back here under your decreased production, and then lymphoma, which is also in that decreased production. So the big way to remember this is when you're thinking of acquired thrombocytopenia, just think of either there's not enough being made, they're being made, but they're being destroyed, or they're being destroyed at the spleen itself. And that'll help you kind of figure out differential and then even go into some of the questions you're going to ask the patient on your HPI. But the etiologies that we should consider that are not part of those three sections that we talked about are the ones that are basically spurious values. You know, clumping or pseudothrombocytopenia always has to be considered. Always repeat that platelet level unless the patient is clearly unstable and you're like, no, I don't need to repeat. I believe this. The patient's actively hemorrhaging and they're not improving, right? But if they're not in that case, then think about pseudothrombocytopenia and you're going to repeat it at a non-EDTA, which is also called a heparinized tube. And that's going to prevent that clumping from forming. Or it could be hemodilution from, you know, excessive fluids or products. I think a lot of us see it and include that probably higher in our differential than we really should in the inpatient setting. You know, but if we see all three bloodlines going down, yeah, hemodilution in the right setting of someone that is actually getting fluid resuscitation is very common in our pancreatitis patients. If we don't think this is from excessive alcohol and the toxin from the alcohol causing thrombocytopenia, you might see in our pancreatitis patients given how much fluid we have to give them. And then clinical manifestations. So we've thought about the questions we're going to ask. We know our differential is going to include the decreased production versus increased destruction. So now what are we going to look for? We're going to look for any evidence of spontaneous bleeding like petechia, purpura. I'm going to have a picture, I think, on the next few slides, as well as bruising. But these clinical manifestations aren't going to happen until a platelet count's less than 20,000. So don't let it fool you and see that someone has a platelet count that's 140,000, which is technically thrombocytopenia. You're not going to see, the body does a good job of being able to deal without having actual clinical evidence of it until it gets pretty low. And that's, again, when you're seeing that level and you get to like the 30 level, you're going to be thinking about actually treating these patients. But you can also get organ failure. That would be probably more consistent with our sepsis patients, as I mentioned in the previous slide, with our increased destruction. But even sepsis in itself can cause decreased production due to direct effects on the bone marrow. This is a cool slide that I saw, or chart that I found in a book that I wanted to include for you guys, because not that we always see a lot of our surgery patients. I think you're more likely to see them in the ICU setting. But if you want to figure out or try to decide what is the association between our platelet levels and days after surgery, you can see that the patient started at about 250,000. They had a surgery. It dropped for some reason around that surgery, whether it's the surgery itself and the stress of it or whatever that surgery was for. Maybe it's a cancer, et cetera. Then we saw a drop of like 50,000 down to 100,000. And then it takes about 2 to 10 days, you know, quite a long time in the inpatient world for that count to eventually go up. But during all these elevations, you can have these conditions that can happen. It can be postoperative TTP. It can be a drug-induced ITP, maybe from a medication they're giving them related to the surgery itself. Maybe it's from HIT, because by day 6 or day 5 is the classic one we think about with our 5 Ts for the timing, that maybe now heparin is playing a factor. Or, you know, if this was one of our endocarditis patients, they had surgery from vascular. Now they have bacteremia playing, unfortunately, a factor into this. And then HIT again can still pop up, you know, days after, depending on its type 1 or 2. And then fungemia would be way back at the end. But this is a cool chart just to look at the timing and based on the multiple medical conditions that can happen to complicate the surgery or the postoperative state itself, and how your platelet counts will affect and how long it truly takes for that count to go up. Because I think in the hospital setting, I'm guilty of this. I just want to see rapid improvement. We're a society of immediate gratification, and we want that. That's no different in the medical world, in all honesty. But know that it can take 4 to 10 or 12 days before we're going to see an improvement in platelet counts because of all these contributing factors. So once we look at the clinical symptoms and we talk to them about bruising, petechiae, all that kind of things, then we do our exam. We'll look for those 2 things like I mentioned about. This is actually purpura that happened in a patient that got quinine, or quinidine, I should say, not quinine, quinidine. You'll look for fevers or chills, other infectious symptoms that may increase your suspicion for the underlying etiology, whether it's HIV, sepsis, et cetera. Joint issues, we're thining about, you know, von Willebrand's or coagulation factors that can play in. And even rheumatoid arthritis or autoimmune conditions on their own can lead to thrombocytopenia through ITP, which may present with just joint issues. There are a few case reports where they're able to diagnose RA just based on ITP as being the first underlying condition. And then looking for potential sources, not just on the body or in the body, but based on your examination of the patient. So looking for catheters, as I mentioned, pacemakers, aortic valves are replaced, or maybe this person has a trialysis cath or is on ECMO. Look for skin breakdown or evidence of infection, signs that might lead to multi-organ system failure, which is what MOSF stands for, which can then lead to DIC, lymphoproliferative disorders, HIT, et cetera, et cetera. But again, you're not going to see a lot of these major findings until you get to the severe level. Less than 30,000 or less than 20,000 is where we're going to start seeing some of these mucocutaneous sources if it's platelets themselves. Von Willebrand's is different. You don't necessarily have the platelet counts that low until you see, clinical manifestations from von Willebrand's. It might, but if you're thinking this is isolated to the platelets themselves, they have to be very low before you're going to see clinical manifestations, which would be the petechiae as well as the purpura and oozing. But hemorrhagic and what sounds like, honestly, like a Stevens-Johnson's or a TEN picture is going to happen when it's very low, less than 10,000. So you might say, like, why does that matter? Not just from a treatment standpoint, but if you have someone that's at that level, maybe if you're on the days and you're presenting the patient to the night team, you might tell them, hey, start looking for these things. You might tell the nursing staff, I know they have 2 catheters in, start looking at those catheter sites to make sure that they're not having any oozing. Or maybe I'm going to prove them to not have as many catheters because I don't want them to have multiple areas that could potentially lead to complications. So if you do the initial workup, you see the clinical exam is going to help you along with your history of what your potential differential is going to include. And assuming the patient's not your less than 10,000 where they're having this horrible mucocutaneous involvement, you're going to say, well, let me just repeat it first. And when you repeat it in the heparized or citrate tube or that non-EDA tube, and it's still low, then here's some of the labs you can get. You don't have to get all these or even this imaging, but this is a conglomeration of a lot of the different sources that I use, which I have at the very end of the slide, that they kind of recommended. So you'll do a smear, as was mentioned in that flow chart. You might get blood cultures if it's clinically appropriate, along with an ANA. Maybe they have some joint pains or things that are pointing towards an autoimmune cause. If you think this person has cirrhosis, as we learned on Wednesday, any person with cirrhosis and ascites, regardless of what they're coming in for, you should get that paracentesis to rule out SBP, which might not always present with abdominal pain. And that in itself can lead to thrombocytopenia, as we talked about earlier. You'll get a direct antibody test to look for, not just your TTH-US, but autoimmune involvement in your thrombocytopenia and some of your hemolytic causes. So that'd be your immune causes for hemolysis, coag studies, which may be deficient in patients with cirrhosis or underlying like von Willebrand's. You could get D-dimers if you think there's a DIC picture. Remember, some of these levels are going to be severely high in a DIC picture. And then if you're thinking multiple myeloma, maybe they had a MCV that was elevated and you're thinking, hey, maybe this macrocytic picture, I'm thinking of myelodysplastic syndrome of multiple myeloma, and they have maybe some osteolytic changes on the X-ray that was gotten in the ER. You could think of an SPEP or UPEP. Remember, the SPEP and UPEP is also going to be part of your workup for some severe AKIs that continue to progress into like a CKD picture because they're toxic to the glomeruli themselves, as we talked about with our nephritic versus nephrotic lecture. And then some medications. I'm not going to go through every single one of these lines, but this kind of helps you get an idea of some of the labs you might order when you're having someone with thrombocytopenia based on that clinical workup that you do. But if you do that blood smear, which is kind of like the second step that I talked about here after repeating it, what would you look at and what might it increase your suspicion for? So if you see platelet clumping, you might think of pseudothrombocytopenia and say, oh crap, I need to repeat this in a heparinized tube. If you see toxic white cells, I've seen this multiple times in the hospital. So that might be someone that is septic or has a septic type picture. I've seen it in patients that have COVID as well here. Doesn't mean that that's a finding always in them, but I have seen it. If they're giant cells, then it could be a macrothrombocytopenia, not as common, but it's something to include. Macrocytosis of the target cells suggests maybe a liver potential etiology, and then your schistocytes. I highlighted in green the things that seem to show up on your boards. So your schistocytes, your helmet cells are going to be your TTP, HUS, or DIC. They love this the second to last column. They really like to ask you those kind of questions on your boards. Malaria does come up, but it's not going to be a patient who randomly has thrombocytopenia. The thrombocytopenia will come up with either malaria, or they're trying to get you to think about dengue fever or chikungunya or some of those abnormal ones. But the way you're going to be able to decipher between those is the location that they truly travel to, whether it's the Middle East versus the Caribbean, which is also, I think Zika is going to be fair game for your boards as well. And when you think of Caribbean, you're thinking more like dengue and then chikungunya as well as Zika. Zika, they're going to have probably a patient that wants to get pregnant because that's been the biggest complication or association that has led to patients coming into the hospital for evaluation of it. Whereas if it's dengue fever, you might be thinking of the break bone pain. And then your lepto, they will present with, conjunctival suffusions or erythema. So this is a slide that I recommend you guys either write down, take a snapshot or whatever to remember, because it does come up multiple times, even during your paras. So we start from the bottom going up. So if we have a platelet count less than 150, we know they have thrombocytopenia by definition. And then if they're going to undergo a major surgery, that's very non-specific. I get it. But think if this person's going through a laparoscopic evaluation for this unknown bleeding or something like that with a high risk morbidity, then if their platelet count's less than 10,000, you're going to give them platelets. If they have a minor surgery, this is going to be like a cholecystectomy, maybe a hernia surgery. Then you might think of levels that are from 50 to 80,000. If you have a central catheter that needs to be placed in the ICU, ideally you don't want it to be less than 50,000 just because of the complications from the catheter placement itself can affect your bleeding and how long the bleeding is going to occur after placement. And then once you get to less than 30,000 is the definition of severe, but I would say less than 30,000 when you should start treating them, but 20,000 can also be considered a risk for doing that. The neurosurgeries are going to be your 50,000 or above is your goal for the neurologic surgeries. All right. So a quick word on ITP, and then I think I'll have one slide and hit, and then I think we should be done because again, I'm not trying to do a full hour lecture for this. So a quick word on ITP, because this is something that I think jumps to our suspicion, our differential, as well as our hemodilution very quickly. But remember, it's a diagnosis of exclusion, primarily seen in our young patients, mostly women, but you can still see it in men only as they get a little older. I don't have a definition of old for you regarding ITP. But we don't really think about it from the 100,000 to 150 range, even though that's truly thrombocytopenia. You might suspect maybe there's a drug or a medication that's inducing it in that range. But once they get less than 1,000 and it's repeated and it's found to be consistently less than 100,000, and maybe the HIV comes back negative, Hep C comes back negative, there are not any medications that can cause it, they don't have any infections going on, there's no family history to suggest this is an acquired condition, then you might be thinking ITP is playing a factor, especially if there's no anemia or concurrent leukopenia. Technically, there's different stages to making the ITP. Or I should say different types. You can have ITP that's newly diagnosed, persistent ITP, or chronic. I just put this in for completeness sake if you want to be very specific on your notes, but just know that in the hematology world, they do divide these into these 3 different categories. But ITP can be secondary or primary, but it can also be secondary to some of these conditions. So when you're writing thrombocytopenia secondary to lupus or secondary to thyroid disease, you could probably technically put that as an ITP secondary to these conditions, but I don't think it's going to be that much of a difference in terms of, except that you're going to treat the underlying condition itself versus giving them steroids or other like IV or plasmapheresis or some other IVIG to help it. Instead, if you think it's not primary, you think it's secondary, you're going to be using the underlying cause as the treatment modality. What's the overview for this? Again, greater than 100,000, typically we're not gonna make the diagnosis. It's gonna happen in less than 100,000. And they're gonna have a long time. If you look at the American Society of Hematology or ASH, which I put the acronym here, they'll allow these patients to wade down from 100 to 30,000 before they actually start treating them, because that's only when they found on case report data that these patients seem to have an increased bleeding risk. So you're going to see a lot of different numbers that seem to contradict themselves, but I wanted you to remember 30,000 in general, because that 30,000 is where, for the ITP, you're going to get treated. 20,000 or so is where the, the clinical manifestations are going to happen. But if you have someone who is less than 30,000 and maybe they are on, or they're starting to have complications, maybe they're having some bleeding, then you're probably going to say, hey, I think this person needs to get treatment for their ITP. I'm going to refer them to the hematologist if they haven't been seen by one already. So if the person's at less than 30,000 and they're going to get treatments, these are the treatments that are going to be considered. Prednisone 1 mg per kg for 21 days, so a high dose of prednisone, and then you're going to taper them slowly. And you're going to do this because they found in studies that if they did a long taper over a shorter taper, then the patients seem to have a longer time before the ITP seemed to return. So their platelet counts not only improved, but it didn't go back down, which it eventually will, as fast as if they were to do a very short course, like 10 days, and then that's it. You can consider IVIG with corticosteroids if you really need a rapid increase in the platelet count. So this is going to be based on their clinical manifestations. They have mucosal bleeding. Maybe they're having life-threatening bleeding. This is not someone that you're going to do just prednisone. This would be someone overnight. You're going to put them on prednisone and then also call hematology about saying, hey, I think this person needs IVIG. I need to transfer them to the ICU for this kind of treatment. So it's going to be based on their, I would say, hemodynamic stability and what's going on clinically before you're going to get the IVIG involved. But for the most part, it kind of sticks with steroids. So when you look at the treatment, it really comes down to immunosuppression. That's the main point of both the steroids and the IVIG. Steroids will be effective in almost 50 or more % of cases, but it depends on the duration of how long you give those steroids. You can also give other things like IVIG, which is going to help clear the antibody-coated platelets, which your body's trying to attack, or you could inhibit those antibodies from even being formed, which is what ITP really is. So you have antibodies that are produced against the platelets, which results in the body trying to get rid of them. So how are we going to prevent those antibodies from even being formed, I should say? We can give them steroids, Azithro, Cytoxan, or Rituxan. And I put in parentheses of the name or what they're targeting specifically. Rituxan does help prevent relapse in about 60% of patients. So I think if you were to try and impress the hematologist, you might say, I think this person needs to be on steroids, maybe some IVIG based on their clinical deterioration. And I think long-term they might do well with Rituxan specifically. If you're going to do urgent management, that's when you're going to get that IVIG involved. But it's only going to be done for acute serious bleeding and platelet counts less than 10,000, which is when you're pretty much going to see that acute serious bleeding occurring. You really should not transfuse platelets in these. Oh, sorry, there's a question. When will I go straight to IVIG versus steroids? Is there a platelet cutoff? There isn't. The 10,000 is that cutoff of where you're starting, because you can still give IVIG from 30 to 10,000. The 10,000 is where you're going to see the clinical kind of decompensation that was probably going to warrant IVIG. So I'd say that if someone presents to you new in the hospital and their platelet count is less than 10,000, they have severe bleeding, they're bleeding from like every IV site, and you need to put in like a trialysis cath or whatever. Maybe they have acute renal failure and they're going to need dialysis, and you're talking to Dr. Seeger about it. That might be something that you're going to do IVIG in, but I have not seen them do IVIG without steroids, to be honest with you. So I don't know if you'd ever actually do that, but you might say, I'm going to get IVIG involved with steroids when you get to that 10,000 level. Hopefully that answers your question. And then you can consider splenectomy in these patients. It was previously considered a second-line treatment, but 60% of patients have seen to have long-term remission. So you might see patients even in the hospital be recommended for splenectomy if they had to get IVIG or even steroids, or maybe they're very close to dying and like, we cannot let this happen again, and we're going to put them on Rituxan, or maybe you're going to let them go on Rituxan, IVIG, and steroids, and maybe they're not having the complete response that you wanted them to, then maybe you're going to consider the splenectomy. But that is a discussion you have to have with the patient, because there is a risk for morbidity and mortality. They're going to have high risk for infections, and they're going to have to get different immunizations as a result of that splenectomy. So it's not something that we're going to jump straight to unless there's clinically a major reason that you would have to take out that organ. And now let's just do a quick word on HIT. I have a few more slides than we've done. It's diagnosed when you see a fall in the platelet count of more than or less than 150,000, or fail in 50% while they're on heparin. So the count drops to 150,000, or you see a fall of greater than 50% of what their count was originally when they came in. There's multiple types. There's two. There's type 1 and type 2. Type 1, it's benign. It's going to happen early on. If you remember that chart that I showed you relating to the surgeries, whereas type 2 is going to happen later on, that 5 to 10 day mark. In that chart, I think it showed it at the 12 to 14 day mark, but the classic is 5 to 10. This is going to be secondary to antibodies being formed against the PF4 complex, which then activates more platelets and it induces that thrombogenic state. Oh, yes, you're right. I missed one extra T, sorry. So what are the 4 T's? This is what attendings like to pimp you guys on. It's the thrombocytopenia, the timing, thrombosis, and then other. So the T in other was technically the fourth T. So thrombocytopenia, increased risk, again, of that greater than 50% fall in platelet count, which is typically 20 to 100,000, or that level less than 150, because you can't technically have thrombocytopenia until you're less than 150 again. Timing, it should occur within 5 to 10 days if you're in that type 2 range, but then it's going to happen within 48 to 72 hours when they have re-exposure. Thrombosis, the increased risk for major vessels is going to occur because, again, you're going to see that this immune complex that forms between PF4, the antibody, and the platelet itself is going to actually activate more platelets to form, which is going to induce this thrombogenic state. And then other causes, make sure there's nothing else that could potentially decrease the overall low platelets, which we just spent the past 45 or 30 minutes talking about. Once you do the scoring system, then you're going to get a score of 6 to 8 that imparts a high risk. 4 to 5 is intermediate. If someone is low to risk, sorry, there's a typo there, it's going to be considered low risk. So how do you interpret those numbers? If they're low risk, so if they're in the 0 to 3 range, you're not going to really perform any testing. You're just going to watch them. If they're intermediate to high, which is a score of 4 or above, you're going to do the testing for the, let me go back, the PF4 and then the SSA antibody as well. It's going to take a long time to come back. So you're not going to wait for that testing to theoretically come back. You should automatically send the diagnostic testing and you treat them for a presumed hit. So you're going to discontinue the heparin. You're going to start them on bivalirudin or edoxaban or some other agents. At this point, you should probably get hematology involved, but that is still within your purview as an internist to be able to manage these. So these are the labs, as I alluded to, your antigen assay, which is looking for the antibodies to that PF4 or heparin complex itself, which is what is then detected by the body that leads to it being destroyed, which results in the thrombocytopenia. It's the initial screening test, but you can see false positives, which is why we do a serotonin release assay, which is SRA. I've always learned it as SSA. But they're gonna mix it with the patient's platelets basically and just see if it seems to go up. So it has high sensitivity and specificity, but it's very high cost and it takes a long time. So what's the overall learning lesson from this is I've not seen people send a PF4 without the serotonin release assay. Most people send them together because of how long it takes for it to come back. But once you send them back because you have enough suspicion based on the high or intermediate score, you're just gonna treat them preemptively. So let's go back to that case, that 30-year-old female that we talked about that seemed to be okay, except they had some spontaneous symptoms that resulted in a platelet count that was persistently less than 10,000 that we knew was not secondary to pseudothrombocytopenia because we repeated it right in the heparized tube and it was still low. So in a healthy non-hospitalized patient, we know that the levels of a thrombocytopenia or levels of platelets only being affected where this is not like aplastic anemia or a bone marrow suppression that's causing anemia and leukopenia is pretty small. So we're really going to limit it, especially again, in a very healthy patient that's not hospitalized. This is an outpatient setting. ITP is going to be very high in a differential as well as drug induced. So maybe they're on an oral contraceptive or some other medication that potentially caused it, or you're going to ask them, hey, did you have any recent upper respiratory infections? I think I have seen recently on PubMed some cases of ITP related to COVID, but we all know that COVID is prothrombogenic. So I don't know if that's related to a DSC picture or what. We're learning a lot about it, but just know that viral infections in general can cause it, as well as hyposplenism, which would be an indication for splenectomy if we think that that's potentially an etiology for it. So I had a ton of resources from ASH, from different books. I used some European sources as well. Hopefully this was a good refresher for you guys. What questions do you have? If anyone is still there. All right, well, hopefully you found it helpful. I think so. I was replacing Dr. Hajar. She had some family in town. So she's been rescheduled to the 23rd, which will be in 2 weeks. Next week, we're going to have a talk from Dr. Doshi. This was one that I requested him do, the localizing neurologic lesions. So that will, again, be recorded and then be available. This has been recorded, so we'll put this up online as well. And then I think that will be my last talk for you guys from a rundown perspective, because then the block is going to be over in 2 weeks. And then at that point, Dr. Schultz is in charge of the rheumatology block, so she'll be doing her own lectures. If you guys do have specific topics that you want me to go over, please let me know. This was a request, so then I did it. I thought it was a great request. but if there's specific ones you want me to do, as always, please let me know so I can provide them to you. If there's any things you want me to change, I'm not going to change. Just kidding. I'll do them. Just let me know what specific things you think is working or not, what's not working. No platelet party pick from Awkward. Oh, I didn't realize that he had a platelet party one. I only focus on the ones that he has stickers for. And since he didn't have any stickers of the platelets, I didn't feel that I should put it up. But Pat, I will put it on my next presentation. I'll make sure that I'm not avoiding Awkward Yeti. They've increased their prices, so he's getting a little cocky over there with his comic. All right, thank you guys, and I will be here if you have any questions. Have a great weekend.